Is my presentation visible and am I audible?
Yes, sir. Presentation is visible and you're loud and clear.
Okay. Uh,
Good to.
Good afternoon, everyone. It is my pleasure to be here amongst our Korean colleagues. And I thank All India Ophthalmological Society and Professor Namrata Sharma, who is our secretary, for providing me this opportunity to present our work here amongst our Korean colleagues. So I'll be speaking on managing giant retinal tears. Giant retinal tears, we all know, are the tears which have greater than 90-degree or more than 3 clock hours of circumferential extent. And even in today's scenario, despite all the advances in surgery, equipment, and techniques, they pose management challenges. Use of perfluorocarbon liquids and wide angle visualizations have helped in achieving us better outcomes. And surgery itself may not be so difficult in today's scenario. In spite of all this, the prognosis remains guarded in these cases because of the high chances of proliferative vitreoretinopathy and secondary glaucoma, which tends to occur in these particular patients. Now, some of the common causes of giant retinal tears include high myopia, trauma, and they can be idiopathic. Even previous intraocular surgery may predispose to giant retinal tears. A special mention about pediatric GRTs. Many of them tend to be associated with syndromes and are associated with hereditary vitreoretinopathy. They have a poorer prognosis and are associated with extremely high rates of PVR. In fact, recently we published this large series of around 100 eyes of pediatric GRT in Nature, and we found that pediatric GRT related RRTs have poorer prognosis as compared to the adult GRTs. And especially the pediatric GRTs are often associated with hypotony and choroidal detachment. Now, vitrectomy is the preferred mode of treatment in these patients, and few considerations include gauge of the surgery. At our center, we prefer 25 gauge, and in fact, we have published a large study a few years back in Retina, where we found that results of 25 gauge surgery are as good as that of 23 gauge surgery. Some people like to combine vitrectomy with belt and buckle, but in first surgery, usually we'd avoid encerclage or belt buckle so as to prevent slippage. And we tend to have lower threshold for lens removal in such cases. And one thing to remember is that please do not preserve anterior capsule in these eyes if you are choosing to remove the lens, as it may and lead to posterior concavity of the iris, which can be problematic in later stages. And as far as possible, we try to maintain the lens so that it preserves the anterior posterior barrier. Now, I'll be talking about key steps of the vitrectomy. Vitrectomy is relatively easy in these eyes, and we first do vitrectomy in the areas of attached retina. In the area of giant retinal tears, retina is usually mobile and is saved for the last. And one has to remove vitreous as much as possible, right up to the vitreous base, and base shave is necessary in most of these patients. Now, by definition, PVD is present in all eyes with giant retinal tear, but in our experience, it is not always the case. For example, you can see here, I did PFCL assisted retinal flattening in this patient, but there are some retinal folds. So what I do is I went back and removed all the PFCL. And once the PFCL was removed, I injected triamcinolone. And to my surprise, PVD was not present. And once PVD was induced, I could flatten the retina with PFCL. It is important to remove even small islands of vitreous, which can later contribute to PVR otherwise. And I do not hesitate to peel ILM in selected cases to confirm PVD. Now, it is important to remove the anterior retinal flap, which is residual in these cases. It is usually functionless, and if we leave it behind, it is a part of it is ischemic retina, and it can lead to proliferative vitreoretinopathy and hypotony later on. So it must be removed with the help of cutter. One has to remove all the membranes Any membrane present previously may contribute to future membrane formation as well. Anyways, GRT is a high risk for proliferative retinopathy. It is best to stain. Usually I stain with trypan blue, and then one can peel under PFCL or without the use of PFCL. And one has to peel these membranes from posterior to anterior and avoid circumferential peeling of these membranes. At times, intrinsic retinal shortening may be present, which may be difficult to handle in these cases. The edges may be rolled in old cases of giant retinal tear. These edges have to be excised, and one may excise with or without cautery. But remember, if they're more posterior, they tend to bleed more. The anterior tears or anterior retina tends to bleed lesser as we excise the edges. Uh, Flattening of the retina is relatively easy with PFCL. Once we have removed all the traction, what we do is inject PFCL slowly in a bubble over the disc surface. If there is formation of fish eggs, one has to wait for the bubbles to coalesce. And once they have coalesced, then we can again start injecting so that there is single bubble. And one has to fill whole of the vitreous cavity with PFCL to flatten as much as retina possible. Once the retina has been flattened, 5 to 6 rows of laser photocoagulation are provided to the edge of the GRT. It is important to laser the edge, otherwise it can roll on in the later times and can lead to retinal detachment. And one has to remember that overuse of laser photocoagulation can also lead to PVR and redetachment. Once the retina has been lasered, you can do either a direct PVFCL silicone oil exchange. The advantages is that there are less chances of slippage, and one can use either bimanual method or a standard method where you are injecting from the infusion cannula. In cases one where you are intending to use gas as tamponade, PFCL air exchange is the only method. The trick is to dry the edge before aspirating PFCL completely. That will help us reducing the chances of slippage. And it is the only option where gas is planned, as I told earlier. Silicone oil is preferred in most cases, except in few fresh cases and superior GRTs where one can get away with gas. And sometimes in patients, pediatric patients, where there are inferior GRTs with PVR, many people like to retain PFCL for medium terms, which can be later exchanged with oil or gas. Post-operative management is important. The posturing is like any other case after vitrectomy. There is high chances of inflammation, so systemic steroids are recommended. One has to watch intraocular pressure closely. And one surgery success rate usually ranges from 50 to 80 patients, which must be told to the patient clearly before taking on the surgery. And if there is redetachment, we do not hesitate to put encircling band or buckle in addition to T-surgery. Now, these are some of our cases. You can see the eyes had GRT, which are nicely attached after gas and after silicone oil, but picture is not always rosy. This is one pediatric GRT which I had operated, and in the post-operative, the retina just went on to become a small bunch of mass at the optic disc. So this is my last case. This is a middle-aged male who had a high myopia and had a corneal tear for which he had undergone repair. He had unaided visual acuity of 6.6 and presented to us with aphakia, corneal scar, and a giant retinal tear. There was history of 1 day and there was period 210-degree GRT. This patient underwent vitrectomy, and after the initial vitrectomy was complete, the anterior flap of the retina was excised carefully right up to the ora serrata. And once the retina was excised anteriorly, PFCL was injected over the disc. Retina was settled. The PFCL was filled up to the brim. Laser photocoagulation was done. And since there was no iris and lens in this particular patient, I chose gas as a tamponade. And this patient, in fact, did well and retained 6/6 vision. And now we have up to 3 years follow-up and the patient doing well. To conclude, the settling of retina with PFCL is a relatively easy task in giant retinal tears. One has to make sure that there are no residual membranes on the retina. Meticulous steps are necessary to ensure proper outcomes, and real challenge is to limit complications which ensue in the post-operative period. And remember, pediatric GRTs tend to have poorer prognosis than adult giant retinal tears. Thank you very much, and thank you for your patient listening.